Dr. Adams, I recently spoke with a constituent whose son is grappling with a substance-based problem, and she mentioned there is a disconnect between what she has been told by experts is the appropriate time for her son to be in a treatment center and what her insurance will cover. So now he's cycled through treatment a couple of times, and this is not the first time I've heard this, which drives me to the question, do you think there is a disconnect between what we know are evidence-based best practices for substance use disorder treatment and the coverage of such programs?
Yes. And I can't say it any plainer than that. We think that you're going to put someone in a treatment program and that in 4 to 6 weeks they're going to be magically cured. We know that recovery is a lifetime, and it's one of the reasons that HHS is focusing on trying to emphasize treatment and recovery and provide that flexibility for states to be able to provide those wraparound services, that transition, that recovery moving forward.
So what would you recommend to close the gap between what is paid for and what is recommended?
Well, again, I can only speak on best practices, not on regulation or legislation, but I will say that it's important that folks look at the fact that you're not going to solve this problem with a short 4-week, 6-week treatment, and that we need to fund that spectrum. And again, we're trying to use the flexibility we have within CMS through 1115 waivers to give states the ability to do that.
It seems to me that this is more consequential the way it's operating now, more consequential to the life of the individual, more consequential when we rotate people in and out and then they get paid for different segments of services instead of
certainly not a best practice, Senator.
An outcome. Would an outcome-based payment system for rehab treatment ensure best practices are followed?
Outcome-based payment is something that we are certainly pushing towards within HHS in a broad array of areas. The whole fee-for-service world, I think, needs to be looked at very closely. We need to make sure we are paying people to actually create health and wellness and not paying people to do procedures or to keep someone as an inpatient until their funding runs out. And again, HHS is committed to providing that flexibility, but also to incentivizing new payment models. If you look at what we're doing through CMMI, we're trying to help states and local entities figure out what works best for them, but to show proof of concept so we can scale it up.
Mr. Mendel, first of all, I have my deepest sympathies for the loss of your son, and none of this is easy. You previously stated you do not support heavy federal regulation, but an approach akin to how highway funds are tied to speed limit changes, for example. Correct. What should the federal government tie funds to in the addiction space? What laws should all states have in the books, and what, if any, laws should the federal government lead on to ensure national uniformity and protection for individuals in recovery?
Sure. Before I answer that, let me just add, there is one federal law that can be, that I think is very important, which many members of Congress are working on right now, which is to require, as part of their DEA license, all doctors in the field and psychiatrists, as part of their DEA license for prescribing controlled substances, to tie it to education. And if that is done, there'll be a huge improvement in the system, because doctors right now can prescribe Oxycontin, Vicodin, Percocet, all opioids, without having any training. And to have, before they are, as part of their license to be able to do so, to be trained in basic prevention and treatment of addiction would be a huge lift to this country. So that's number one, what the federal government can do. Then, to answer to your question as far as what leverage the government can do, per your example, with a 55-mile speed limit. Number one, conformance, state medical societies conforming to the CDC prescribing guidelines would be a huge lift. Requiring states to follow a quality measurement system like ours. Ours is the only one out there right now, but there could be others, so it's not specific to us. Tying it to state funding that's coming from the government, only going to evidence-based, to treatment programs that are following evidence-based practices. Again, that relates to a quality measurement system, so you can determine which treatment programs are following evidence-based practices. Requiring medical schools in their state to have basic training on prevention and treatment of addiction. I mean, there's 3 right there that would be significant improvements to the system. And if I can add one more federal legislation to eliminate Data 2000, which requires any doctor in this country who wants to prescribe buprenorphine to go through a significant process with the DEA, licensing, hours of training, oversight by the DEA. Doctors can prescribe OxyContin without any additional training. Why do they have to go through this whole process to prescribe buprenorphine? The result of that is less than 5% of the doctors in this country can prescribe buprenorphine. Less than 50% of the counties in the United States have even one doctor prescribe buprenorphine. There's legislation now in Congress right now to eliminate Data 2000. I would highly recommend that.
Thank you very much.